My name is Michelle Zechner. I'm faculty at Rutgers School of Health Professions at the Department of Psychiatric Rehabilitation and Counseling Professions. I've been helping people living with mental health conditions and their families for over 20 years. One of my passions is learning about new services to help people recover from mental health issues. Welcome to Mind Care Matters, a podcast series dedicated to exploring new and innovative strategies to improve mental health. Today, I'm delighted to be talking with my colleague, Dr. Tameika Minor. Dr. Minor is faculty in the Department of Psychiatric Rehabilitation and Counseling Professions and has expertise in rehabilitation counseling, specifically focusing on individuals with co-occurring substance use disorders and mental illness, transition-age youth, and returning citizens. She is the principal investigator of a Health Resources Service Administration or HRSA grant focused on the interprofessional treatment of co-occurring opioid use disorders and mental illness. Dr. Minor also studies cultural competence and the recruitment, retention, and mentoring of faculty of color. Dr. Minor holds a PhD and master's degree in rehabilitation counseling from Southern Illinois University and North Carolina Agricultural and Technical State University, respectively. Welcome, Tameika. I'm so grateful for your time.
Thank you so much. I'm so glad to be here today.
Well, today we are actually going to be talking about the value and importance of integrating physical and mental health care. And this is a topic that's near and dear to my heart. So I'm so excited that you're here and going to be talking about some of your work and some of your thoughts about this. So let's start out with, what do mental health providers need to know about integrating physical and mental health services?
So I like to say I kind of fell into this a little bit by accident. But when I fell into it, I fell in love with integrated care. So integrated care is not a new phenomenon. We're just beginning to see more and more of it. In a nutshell, integrating mental health care services really came about due to patient interactions. So we see that patients are more likely to discuss any mental health issues that they're having with their primary care doctor. So why is that, you may ask? That is because they have that rapport. You know, some folks have been going to the same primary care doctor for decades. I know that's always been the case in my small hometown where there's, two primary cares and they're always there. Also, it may not be seen as stigmatizing just to go talk to your primary care doctor doing a routine checkup. And it's convenient. We see that if you're going to take your annuals, you'll talk about these issues. If you're having a concern, for blood pressure, you'll talk about these issues. And also it really helps for folks that just don't have the access that we see in what we call medically underserved areas that don't have access to behavioral health care or healthcare services. A big one that we see is such as dentistry. So that are a little bit of the benefits that we have seen on the patients end, but there's also benefits that we see for doctors, for staffs also. We're seeing, of course, better health outcomes with our patients, better medication adherence, more effective communication has been happening throughout providers, especially as we see with substance use disorder and mental illness. And for our providers, we're seeing less burnout, we're seeing less turnover, and also more continuing education as we're all learning about the different disciplines that are in professional care. So a little bit about looking at the education and training in interprofessional care. There are several models that are out there, but I have been mostly trained in what we call the IPEC competencies, which are the interprofessional education competencies. And that has actually been the basis for the 3 training grants that we've gotten here at Rutgers.
Oh, wow. Congratulations. Wow, 3 grants.
Yes, we've had 3 HRSA grants, and that's actually how I got into it by accident. I started working on our first HRSA grant, which the principal investigator was Dr. Barbara Caldwell from the School of Nursing. And that was also a partnership with social work and our department in psych rehab. And I started working with our program director, and I really got into it. And it was really cool because I actually got to supervise our counseling students at Virtual Hospital. Wow. So it was really being in the action with it all. So I really enjoyed that. And IPEC really helped with learning about interprofessional care and also training our students and professionals as well. So there are certain domains in IPAC, such as effective communication, diversity, teamwork, and best practices. And with interprofessional care, so there's always the big misconception of what's interprofessional care and what's co-location. So sometimes you'll hear folks, oh, I can go to my primary care doctor and there's a pharmacist right there where I can pick up my prescriptions. And oh, there might be a behavioral health therapist where I can sit, and talk to them for a second. But that's not integrated. That's co-location. They're all in the same building. What we have with integrated care is there are certain signature components. So there's one that we have called the morning huddle. So all of those professionals, such it could be your NPs, it could be your MDs, the social workers, the counselors, dietitians, everyone that is meeting on that team, we discuss who's coming in that morning. What have been the primary issues that that patient has been discussing, and then maybe who's going to see that person first. There's also a signature component called the warm handoff. So for example, let's say you have a patient that comes in to see the family nurse practitioner for a blood pressure med refill. So that patient may be discussing that they have been eating some foods that aren't too great for their blood pressure. They see that they've been over consuming in some of those foods, but they also have been having trouble getting out of bed. They're having low energy and they just, may feel downright blue. So the nurse practitioner can then say, would you like to speak with our behavioral health professional that's on staff today? That could be a social worker, that could be a rehab counselor. That nurse practitioner would then go, what we call is we kind of nest all around, can go grab that behavioral health practitioner, come in, and they would introduce the patient and the behavioral health practitioner right then and there, do a rundown. Let's say Mr. Smith was here today for a blood pressure med refill, but he's been discussing of having low energy, feelings of sadness, not being able to get out of bed, and over consuming in some foods. And that's what we call that warm handoff. So that's when the behavioral health tech would take it from there, and they would discuss and go from there. And possibly we can get Mr. Smith back in for another appointment.
Wow.
So also signature interventions that we use with the interprofessional care and integrated care as well, such as motivational interviewing and solution focus, because anyone can use those. We've been able to train our social workers, our nurse practitioners to use those brief interventions, and also SAMHSA's expert model for screening, brief intervention, referral, and treatment for things such as substance use disorder, mental illness as well. And we've just seen great results from using integrated care.
Oh, that's really wonderful, and you've given me a lot to think about. You've unpacked a lot of information, and I want to kind of circle back a little bit, if that's okay.
Sure.
One point I think that you made, which I think is so valuable for our listeners, is that integrated care really improves access for people who may not otherwise have access to behavioral health services if they're sort of already receiving care from primary care, and then they need something, then they can get that access immediately. And I think that really sort of helps to break down the barriers of the mind-body connection. We always joke in behavioral health that, there's your brain and then there's everything else. In mental health, we often focus only on your head and we don't talk about your body. And can you speak a little bit? I mean, you started to give some examples, but so are these integrated models, how do they help with coordination of care?
Integrated models have been great for coordination of care, especially as we've seen in underserved communities. So that's one of the focus with HRSA, is that they do give these grants to areas that have large amounts of medically underserved areas, and they do have a screening system and a whole bunch of formulas that they use for that to see where these will best be needed. So here in Jersey, especially in South Jersey, and you would think, with Jersey being a very wealthy state, very diverse, that We have a lot of medically underserved areas, Atlantic County, Camden County, parts of Essex County that we see, Mercer County also, where there's just not the access. And a lot of those have what we call FQHC, Federal Qualified Health Centers, that do practice these integrated models. So patients are able to get that holistic care that they need. They're able to get their physical health care. We've also seen specialty services at some of those, such as women's health as well. One of the FQHCs that we work with does offer a medication assisted treatment program. There's behavioral health program. There's OBGYN. There's also children's services, and they're conveniently located mostly through on main public transportation lines where people can get to. The staff is trained in these issues for working with persons from from more diverse areas. And it just seems that patients seem welcome, it's not as stigmatizing, and that wants them to go back and to get the care that they need. And this coordination of care, also we have a shared EHR now with integrated care. So
wait, I'm gonna stop you there. EHR, tell me what that is.
Electronic health record.
Okay, thank you.
So every professional that's working with that client, patient, you can see what is going on within that care. So that really helps with coordination of care also.
Great. Well, thank you. Yeah, that sounds like it has a lot of potential. And you mentioned two models, and I'm going to ask you to sort of describe them again, because I think it's really important for us to understand. You mentioned something called the IPAC, I think.
Yes, the IPAC. So the interprofessional education competencies is what we have trained our students in from our grants, and also is one of the leading models that we do use for interprofessional education. So there's 12 domains, don't know them off the top of my head, but some of them are like effective communication. That's one that I really enjoy to learn about, is effective communication, because one thing that I noticed when I got into this work is a lot of alphabet soup. You have like, for example, EHR. What? I didn't know what EHR was when I first came in. And when the more, medical staff, the nursing staff would talk, the MDs, I think might as well have been speaking, French. I had no idea what everyone has their own language. So one thing that we teach is, trying to have some type of common language that we can use that can better serve our patients and clients. That's another one that you might hear me even using that interchangeably, because in the helping professions, we have clients. In the medical world, it's patients. So it was when I would say clients, the medical folks would look at me like, what are you talking about? This isn't like, no one's coming here to lay on your couch, because they do have that misconception of that is what we do.
Wow.
And as being rehab counselors, I can say I think that Rutgers, we have been one of the pioneering rehab counseling programs that has been into integrated care. So from the time I've been working with HRSA for the past 6 years, every conference that I went to, every workshop that I went to, I was the only rehab counselor. No one ever knew what it was. Of course, folks were like, oh, you work with substance use. Yes, I do, but that's not just what rehab counselors do. And I remember my first HRSA conference, and I'm looking at all these universities, and I'm like, you have a rehab counseling program there, right? It's probably within the same building. Why don't you check in with them to see how you can add them to your team? Because it seems we're just last to be chosen for the softball game. But what I have found is, since we've been in integrated care with our students who have been training, they came in, were professionals, patients, clients, had no idea what it is that we do, but then they became one of the MVPs. They were who everyone went to. And it was just published this year, a case study from the School of Nursing, which they have got funding from the American College of Nursing Association. I'm sure I'm probably butchering that, but they wrote a integrated care case study, and I contributed to that by just saying what it is that rehab counselors do. So I gave top 10 things you need to know about rehab counselors and how I feel that we're every state's best kept secret.
Oh, wow. Well, to me, that's really amazing. And I think, what you're saying really is that we speak a different language. Like in health, it's so important that we're on the same page, but we're really in different fields. And I've done some work in this area too. And I love working with dentists and physician assistants and all occupational therapists. I mean, when we are together, we learn so much from together. And I think you're right. Rehabilitation counseling offers so much. I mean, I'm in a psychiatric rehabilitation perspective, but that rehabilitation perspective, I think, offers so much, especially for healthcare, because we're talking about recovery. We're talking about people getting better in their health and whatever domain they're challenged with.
Absolutely. It was really interesting, like that first year to learn everybody's lingo. I thought my head would explode. And it's like, we kind of all got to get on the same page of what we're talking about, because we got to talk about our clients and our patients also. But it also helps with learning each other's roles as well, and who does what and their scope of practice. And also one thing that I did find out, there's implicit biases in the professionals. I actually have a research study going in on that now. There are implicit biases within the professions. And I'm like, really? And so learning that piece from IPAC, the effective communication, teamwork, what everyone's role is, we hope to, break those biases so we can be all able to work together. Like, it's a great model. It's not a perfect model. It does have its kinks, but that has been one that I think is one of the unspoken ones that I've seen.
Yeah. And so I think you're already talking about some of the limitations of integrated care. And that was going to be sort of my next question, is it sounds like you're saying that there are some misconceptions and biases of professionals with other professionals. And it sounds like there's a lot of training that's needed in order to offer it. And maybe I'm misunderstanding what you're saying, but what are some limitations to the integrated care model that you can think of?
So some of the limitations, for one, is that and we found this out in our practice, a lot of the agencies that we were working with were like, yes, we're integrated. And they're not. They're really co-located. Just because you have the pharmacy or you are a mental health agency that has a MD or a nurse practitioner come in twice a week, that's not integrated, because you're still not doing a lot of those signature pieces. It's just, okay, Monday and Wednesday, the doc is here.
Gotcha.
No, still communicating with each other. Okay, yeah, you can go on, floor 3 to pick up your meds, but that doesn't mean the pharmacist is talking to the providers. It's just like, okay, there's a CVS here. It's really no thing that we see. And we saw a lot of that. Came with a lot of arguments, because it's like, okay, we're the visitors here and we're telling people that they're doing this wrong. A lot of folks really were, and we didn't get a lot of pushback. Some people were really like, can you help us be more integrated? And so that's where we did, with our grant, we're able to offer the training to those practitioners for the agencies that we were working in. So that was one of the biggest limitations that I saw. And that also led to folks still being in their silos. Especially when it comes to substance use. So substance use and mental illness, the golden standard is to have this integrated care. But we were still having substance use facilities that may sprinkle on the mental health care, and vice versa was like, oh, the mental health care, we're going to focus right here on that mental illness and not really looking at physical, not really looking at the substance use piece of it all. And I found those to be the biggest offenders of the co-location integrated argument of things. And it's, well, we're here to treat, the substance use disorder. We're here to treat, whatever. And we also would get that a lot from clients also too, but that's the tricky thing about co-occurring. As we see, research has shown most folks that have a substance use disorder have an underlying mental illness, or those that have a mental illness are self-treating with some type of substances that we see. So we saw something like, I don't want to talk to a counselor. I'm just here, for my substance use treatment, whatever that would be. So that was another limitation that we saw also. Also with the medication assisted treatment programs that we saw, a lot of them weren't communicating with the physical health piece at all. And then also a lot of the clients were kind of like, I just want, my Suboxone or whatever medication that they were on. And one part of MAT, which is federal mandates, that you do have to have mental health counseling, but the physical piece was still going on, because we do see a lot of physical conditions start to happen with persons that have substance use disorder. A big one is dental care. We like certain substances, I know, like methamphetamine, cocaine use, it does a lot on the teeth. And sometimes when people are in recovery from those substances, they tend to pick up sugar habits. And you get a lot of the cavities and things such as that. And dental care in my I've been working with this, dental care is so hard to come by. It's so hard to come by, especially because, for one, it's not affordable. A lot of the free dental or sliding scale have very long wait lists. And as a rehab counselor, when working with those clients and those who were in recovery, who wanted to get back to work, would be very self-conscious because of their smile. And it's, how do we work with dentistry to be able to get them the dental care that they're needing? It was pretty interesting. So we worked, a highlight of our program was that we actually worked at a mid-level prison. And a lot of those justice involved individuals, one of the top, I want to say 5 things that they looked for was dental care, because they were receiving dental care while they were incarcerated. Also wraparound services. Where were they now going to go for their mental health and substance use care, because it's not there now, and knowing how to advocate for themselves was something that we really work with. So I saw a big limitation in certain populations with getting wraparound care, especially those that were justice involved.
Wow. Well, that's really fascinating. I mean, you've kind of talked about some of the limitations, which are fascinating to me to hear, not only the siloed care approach from the professionals, but also clients or service recipients or patients or people receiving our services, however we refer to those, not understanding an integrated approach. And yet this is so much like person-centered care, stuff that we've seen for years that started out of England, this person-centered care models. And I just want to touch on the dental care. I think you're just so right in all of the external reasons that people have challenges with that. I've done a little bit of research with dental students and looking at their attitudes about people with mental health conditions. And we've published a couple of papers on that. And that is a fascinating and really needed area. We all need to advocate for better oral health care for everyone, and particularly people with substance use issues or mental health conditions. And lastly, I just want to ask you about some of the current trends, but it sounds like you've already kind of told me a little bit. I mean, it sounds like justice involvement with integrated care might be one of them, but what are some of the other areas you're seeing?
Yeah, so justice involved individuals is one. So as we said, there was the mid-level prison that we were working at was actually at the time when we began working with that correctional facility was the only one that had a MAT program for those who were incarcerated in the state of New Jersey. And we're really open to having that integrated care model. Of course, unfortunately, we're still very much in the opioid epidemic. We've seen it getting worse with fentanyl that is now being laced within everything. So that's where the basis for my grant came from with HRSA, and that's how we started the CISATAR program, Community Integrated Services for Addictions Treatment and Recovery, is to train professionals to work with those with co-occurring opioid use disorder and mental illness. We've seen so much more resources that have been available for folks that are wanting to work with this population as well. And then also, I want to say, and I think I might be a little biased. So I think this was a lot to do with rehab and rehab legislation that we've seen, such as WIOA, and that we want to really help our transition age youth. So that 15 to 25, we've seen a lot more services for transition age youth, and that is how we've started the Ruby program, which is our third integrated healthcare grant that we have.
Awesome.
That one actually the principal investigators are from the School of Social Work, and I'm also working with them as faculty. So we've had a great run with social work and nursing. We've all been can't get my words out. All three of us have been involved in the 3 interprofessional grants that we've had with HRSA. So Ruby is Rutgers University for Behavioral Youth. And those same 3 disciplines are working with agencies throughout the state of New Jersey that do offer care for transition age youth with behavior issues. So not only are we in specialized mental health clinics, we're in schools, we've been in community colleges, we were at a university in PA. So it's been awesome to work with transition age youth. Also, we've seen, unfortunately, the rise in behavioral health issues. We've seen the rise in substance use, in suicide. So I think that this program is very much needed, and also for the focus for our youth. Some of the signatures that we do with Ruby is that we do have a mini conference every spring. This is our 2nd year with Ruby. We do have this program for 5 years. Our students are also a part of a stimulated training. So they actually have stimulated patients who are actors, and they actually work out a case study that they're able to put what they've learned together. And they're still also doing that within their sites as well. So that's been a little bit of some of the trends that I've seen. I would really like to see dentistry get more involved with this, as we've seen such a high need for dental care within these populations. Also, I do research with one of my colleagues in poverty trainings and poverty interventions, which is so needed with integrated care, because we do see majority of our clients are from low income areas.
Wow. Well, Tameika, you have done so much and so many interesting things to really make a difference in care. And I'm so grateful to be talking to you today. I just want to kind of wrap us up. How can someone learn more about this topic? If we've talked about a lot of things and you've introduced a lot of new ideas to me, how can someone learn more?
Absolutely. So CISATAR, we do have a website, CISATAR, SICATR.rutgers.edu, where all of our webinars that we've had over the years are recorded and posted onto the website. There's also a community of practice on the website for students and also for professionals as well, where they can share ideas, also get resources and whatnot. And the curriculum is also available.
Oh, wow.
On the CISATAR website as well. Also, HRSA.gov, SAMHSA, There's a lot of information on integrated care as well. The MHTTC, the ATC as well, the Addictions Transfer Technology Center does have a lot about integrated care within addictions as well. And HRSA does offer a lot of webinars and training as well. And then there's Knockout Opioids with the New Jersey Division of Mental Health. They do have a lot of programs as well too.
Wow. Well, Tameika, thank you so much for the amazing work you've done and on all of the resources you've offered our listeners. I can't tell you how much fun I've had in this conversation.
Yeah, I've had fun too.
Well, good. Well, thank you so much, Tameika. I hope that you've helped our listeners get some new models and ideas for how to offer integrated care.
Absolutely. I hope so too. Thank you for having me.
Yeah. This podcast is a production of the Northeast and Caribbean Mental Health Technology Transfer Center at Rutgers University and made possible by funding from the Substance Abuse and Mental Health Services Administration.